So thank you. It's a pleasure to be here. Thanks for the invitation, Hamish, and the organizers. And I'm going to talk to you today about the Amulet study, or abbreviated magnetic resonance imaging versus ultrasound surveillance for liver cancer detection. I will start with just a recap of what we've heard already today, and that we know that people with cirrhosis are at risk of getting HCC. If we catch the HCC early, we can treat it and cure it. And the guidelines recommend screening with ultrasound scan every 6 months. But we know that despite screening, some early tumors are missed. So we missed an opportunity to diagnose HCC early and treat it effectively. And we've heard that there's a clinical need, partly because of the changing demographic of liver disease that Hamish talked about this morning, and the use of ultrasound. The data for ultrasound come from studies that are, in many cases, 20 years old, and they include people with hepatitis B and C primarily. So there's not very much data on ultrasound in muffled and alcohol-related liver disease, which is what we see mostly in the West. So is ultrasound screening effective in populations with steatotic liver disease? And then we've heard in the last session about risk stratification and how that can be improved, and how if we can use a risk-based surveillance, it might improve our practice. And there are loads of risk scores, some of which are listed there, but there are others, and we've heard about them already. And I will just give a couple of examples of how, just to illustrate the problem. First, something from our own practice. This is a 62-year-old man we've looked after in Oxford about 10 years ago, who was referred to the GP by the GP with abnormal liver tests. It was clinically evident that he had liver cirrhosis, and he had 2 ultrasound scans in the same year, one in May, one in November, and they reported no focal liver lesions. There's this heterogeneous liver parenchyma is reported, but no focal lesions. And then he comes to take a part in one of our MRI studies. We have an interest in quantitative MRI scans, and we recruited him for that study because he was happening to have a liver biopsy at the time. And we pick this lesion on the quantitative scan, and he goes to have a diagnostic scan subsequently, which shows an advanced HCC. So illustrating the point that non-contrast MRI can pick up lesions that are missed on ultrasound. And at the same time, colleagues in Nottingham went one better. So this is a case series of people who were treated for hepatitis C with the new DAAs at the time. And on the left, you can see the pre-treatment scans. So these were done as part of the research study that was evaluating what happens to the liver before and after treatment. This is the end of treatment scan, and this is the scan they had when the HCC was diagnosed. So again, and if you look at these images, the HCC is there at the time of treatment, so had been missed by the standard of care ultrasound scans that these people were having. So this is from our own practice. What about the literature? And I think this chimes with what we've heard from the last speaker, that there's a lot of bias or risk of bias in the literature, particularly for non-contrast enhanced MRI. There's loads and loads and loads of publications looking at MRI and non-contrast enhanced MRI, but if you look at them, they're all retrospective case control studies. So I don't think we can make very good conclusions from those studies. There are 2 prospective studies, both non-randomized. One is from Korea, was published in 2020, and one from Australia, published in 2017. And they have slightly different MRI protocols. So the one from Korea looked at T2-weighted imaging and diffusion-weighted imaging, and they found that MRI was superior. The one from Australia, slightly different MRI protocol, so they only looked at diffusion-weighted imaging, but they found that actually ultrasound was superior at picking up liver tumors. So this is what we have so far. But what about going forward? And if we look at the studies that are happening around the globe, this is an area of great interest. Big studies at the top here, one from the USA, the premium study, aiming to recruit 4,700 people, randomize them to MRI or not. They are using contrast in their MRI scan. The fast track study from France and Belgium, they're using a non-contrast MRI scan, and they're looking at cost effectiveness. So they've gone the whole, their endpoint is cost effectiveness. And then a number of other studies, most of them single arm and non-randomized, but looking at diagnostic accuracy for HCC. So this is an area of that's hot. It's active research. So how did our study transpire? I just want to introduce the DELIVER program here, which a lot of you would be aware of. It's a program led by Professor Barnes from Oxford, funded by CI UK, and it aims to develop new tools for diagnosis of early HCC. And in that program, we have the PEARL study, which is a prospective cohort of 3,000 people with cirrhosis that will be followed up for the development of HCC for up to 4 years. And we were partners in this program with our colleagues from Nottingham. And as part of the study, we wanted to develop an MRI study that would look at the role of abbreviated MRI scan as a screening tool in people with HCC, leveraging the PEARL cohort. So we put together a study which has two main objectives. The first is to show feasibility of conducting such a study in the NHS, and the second is to compare the sensitivity of MRI, non-contrast MRI and ultrasound as surveillance tests for HCC in people with cirrhosis. And then a number of secondary objectives, including measures of quality of life and anxiety, which we heard about earlier, about how important anxiety is around this surveillance test. And that was one of the things that came out of our PPI work when we were setting the study up. This is our study design. So this is a single-arm study. We are recruiting people with cirrhosis suitable for surveillance and who have a high risk of having HCC. So 3% per year is where we define the risk. And Hamish does some clever statistics that tells us that if we include such population, we will get enough people with HCC to be able to compare our tests. So we're aiming for 300 participants. They're going to come and have 6 monthly ultrasound scans as part of their clinical care, an MRI scan without contrast in addition. The 2 scans will be reported blinded from each other. There will be a number of questionnaires. If no suspicious lesions are reported, then they continue with surveillance every 6 months until the end of the study, where they all get an MRI scan with contrast to see if we've missed any cancers. If a suspicious lesion is detected, either on ultrasound or on the MRI scan, then they have a clinical diagnostic MRI scan with contrast to look for cancer. And if there's a cancer, they get treatment appropriately. And if there isn't, they go back to surveillance. This is our timeline. We were asked to have a feasibility pilot study, which is why feasibility is one of the main objectives. So the study is about to start next week. We hope to start recruitment in November, and we have to recruit a minimum of 80 people by July of next year. If we achieve that, recruitment will continue until April of 2026, and then a follow-up period for another 2 years, and then completing the study by April 29. As said, the main clinical study is to determine the sensitivity of the test. We have a mechanistic sub-study looking at the liver tissue parenchyma with quantitative measures. We have a very extensive PPI representation in our study. We have a co-applicant and a PPI coordinator, members of the team. We have a PPI advisory group with representatives from patient support groups, and we will have an independent PPI member in the study steering committee. The team, so team from Oxford, Professor Barnes, as I said, we have a data manager and a health economist. the team in Oxford who will look after the MRI physics aspect with Professor Francis. Jamie, you've heard about from up earlier. He will be the lead radiologist. Hamish is leading the statistics, and our PPI coordinator and representative from the Nottingham University Hospitals in Nottingham. The study is funded by the NIHR EME. Many thanks to all those who have supported the study in the early phases and gave us letters of support. We hope that you will become PIs and still be interested to take part in the study and help us with the recruitment. We had support during the design phase, but also ongoing support from British Liver Trust, Hep C Trust, and Hemochromatosis UK, and then we had support from Basel and BSG. Thank you for listening. I'm happy to take any questions.